Dr. Shobhoshachi Roy is a consultant pediatrician in Divine Childcare Unit, and he retired from MR Bangur Hospital, Kolkata. His areas of interests are pediatric pulmonology, pediatric neurology, and he is the recipient of Swasthya Samman. Dr. Sudhir Suvar Raman, he is affiliated to the Madhava Nursing Home, and his areas of interests are asthma, allergies, and vaccinology. And to talk on this topic, I would invite Dr. H. Parmish, none other than Dr. H. Parmish. His topic is allergic rhinitis is an underdiagnosed entity. It's correlate with asthma.
A very good afternoon to everybody. A very interesting topic, allergic rhinitis. As we all know, it is a very underdiagnosed condition. And we also know that it is one of the most common comorbidity that is associated with asthma. And rightly so, the luminary of respiratory medicine, Dr. Parmish sir, is here to address it. All eyes and ears to Dr. Parmish sir. Thank you.
Respected chairpersons, distinguished delegates, while thanking the organizer for giving an opportunity to share some of our thoughts with you, they've included allergy. Pulmonologists never used to like this allergy-related issue. Especially they always used to fight. Anyway, they've included, I'm happy for that one. And also, I bring greetings from my institute. The VHS Center Climate Change and Indian Institute of Science is a 103-year-old building. Started from Calcutta, has got a relation to that one. Anyway, the topic is specific for me. Allergic rhinitis, it's an undiagnosed entity. Why it is, and how it is correlated to asthma. These two issues I am going to cover. Now, if you say the allergic rhinitis is a chronic IG-mediated disease of nasal mucosa, characterized by four things: sneezing, itching, watery rhinorrhea, nasal congestion. It's a major comorbidity of asthma and sleep disorder breathing. It's a major psycho-socio-cultural economic burden. We have related to asthma. Let us not cover that one at this stage. How commonly we come across in our practice? A general pediatric patient, in our own studies in 1994, I used to see only 22.5%. It's steadily gone up. In 1922, we got 50% of the general pediatrics, we have the allergic rhinitis. If you look at the asthmatic children, in them, in 1999, 75% of them had allergic rhinitis. In 2022, it has gone 100%. Why we are not diagnosing this in children? 2 points are there in children, 2-3 points are there in physicians. We have a problem. Why it is? Because children are unable to explain, verbalizing their symptoms, number one. Number two, they lack the acknowledgement of the problem of the children. And many of we doctors, we misdiagnose it by not asking few questions to the mother. One is, does your child snores? Is the mouth breathing? Is he grinding teeth at night time? Is the sleep is disturbed? Is he rubbing his eyes? Is it hyperhidrosis? These are all the questions we should have. They're related to allergy. And also, second thing is allergic mark. If you look at the various curves, the allergic mark curve showing change in the prevalence of allergic rhinitis at the age of 2 years. That is what we are focusing more on that one. I think if you look at that one of the studies shows 60% of the allergic rhinitis have conjunctivitis. Some with only rubbing of the eyes, it is 60% of them. One is redness. Redness, our own study shows nearly 27% of allergic rhinosinusitis conjunctivitis, we call them. Having said that, let's move further. Look at this curve. Only at 2 years, the allergic rhinitis curve goes up. So the allergic rhinitis, the change in the prevalence is observed only at 2 years. That's why we don't recognize. We can recognize the clinical symptoms even at 6 months old children. Having said that, nasal health is a major concern in India. And in the December 2021, nearly 12 people we all met. 11 adult pulmonologists, 1 pediatric pulmonologist, I'm there. My late friend Ashok Mahashur is involved in this one in Mumbai. I missed him. And we published it. That is a pollution-induced allergic rhinitis have been enumerated in this article is becoming major problem mainly from the air pollution. 10 micron always affect the upper airway problem. Now, how do you diagnose allergic rhinitis? 4 symptoms. One is sneezing, watery rhinorrhea, itching of the nose, and nasal congestion. 2 or more of these symptoms more than 1 hour, most of the days is called allergy. It's a simple clinical diagnosis. Somebody wants something, you can do some study, supportive evidence. This is the study, SMART-2 study, where I was also, 9 countries was involved, involving about 2,200 people, either pulmonologists, allergists, and pediatrician, general pediatrician, pediatric, allergist, pulmonologist included. It showed 93.3% of them are the major symptom is sneezing. Rhinorrhea, 89%. Nasal congestion, 85%. And important other problem with the rhinitis is the quality of life. Sleep disturbed breathing in 64%, mood changes in 62%, physical activity disturbance 50%, work performance disturbance 42%. And this is one important thing. This lady, Donna Griffith, she sneezed for 3 years continuously without any break from January 1981 the 16th of September 1983. Sneeze, sneeze, sneeze. Nobody has found out why it is, what it is. That it helped us, where is the sneezing? And I think it's 2000, we found out where the sneezing center is there in our body. Sneeze center is situated in the brainstem. The afferent nerve comes the trigeminal from the ophthalmic and maxillary branches. And you won't sneeze during your sleep. So this is one we found out, some research has come, we found out where it is now, sneeze center, nerves are involved. Maybe pharmaceutical people have to look in that angle, find out the, stop the reflex, some medications. Now I think if you ask anything, sneezing is there, or maybe it is cold, or maybe it's allergy. These 2 things most of us will diagnose. But during COVID period, because most of these people have a nasal blockage, nasal rhinorrhea, and sneezing, are you sure it is not COVID? Many people will ask about it. How do you say that? COVID, you have the constitutional symptoms, include diarrhea, maybe some of the anosmia. But if any allergic rhinitis, if you have itching is the most important. If you have conjunctive rubbing of the eyes, redness, rubbing of the nose, knees itching, that is allergic rhinitis. These are all these 2 clinical features identified. Now, only 2 things. There are about 13 other conditions where you have sneezing. Many of us, we are not aware of it. Only think allergy or cold. Other thing, what are those? Photic sneezing, exposed to so much of sunlight, people start sneezing. Periauricular corneal transplant surgery, because ophthalmic nerve is involved, they start sneezing. Gustated reflex, while you're eating, food hits the top, you start sneezing, water coming through the nose. And NAIRS, non-allergic rhinitis, eosinophilic syndrome is there. Idiopathic, vasomotor, non-allergic, non-eosinophilic rhinitis exposure to the cold and dry air. Occupational rhinitis is there. Physical stimulants of the retirement nerve, pulling off the hairs, pulling off the eyebrows, you start sneezing because nerve related. And also you have the central nervous system, pathology, epilepsy, before epilepsy, somebody starts sneezing. Psychogenic is there. And sanitization reflex, that is sneezing. So that if you had too much of food, stomach is full, you start sneezing. And sexual ideation and orgasm, the nasal reflex neurosis is there. Many drugs will be there. They can produce sneezing, paroxysmal sneezing, at the onset of syncope. These are all the various 13 other conditions is there from the sneezing. Now, the cough is another symptom. 57% of the allergic rhinitis present with the recurrent cough, 40% of the nocturnal cough, exercise-induced cough about nearly 30% of the time. And diagnosis of allergic diagnosis, the clinical history nearly 99%. Serum total IgE to either atopic, non-atopic in 52%. Eosinophilia in the nasal mucous membrane, 50%. X-ray, CT, we don't order any further unless you have to operate something. Allergic skin scattering, 39% had from this SMART studies. We classified based on various things. We prefer our study shows, allergic rhinitis study, we want to symptoms only because it's convenient. Depending on the symptoms, you manage that. If it's runners and sneezers, usually the antihistaminic helps. It is mainly from the pollens and fungal. Blockers is usually the controller medication has to be added. This is what we have been using our own study. How do you grade that one for various reasons? Whether based on the rule of 4, whether intermittent or persistent, is it a mild or a severe? These are all the 2 things. We'll do this one. 4 symptoms are sneezing, watery rhinorrhea, itching of the nose, nasal congestion. If it is more than 4 days per week, if it is more than 4 weeks per year, it is persistent. Less than that one is intermittent. Then come back again for, is it mild or moderate, based on how long to treat, which one to medicine to use. These 4 symptoms are activity, schooling, sleep disturbance, troublesome breathing. If there are none of them, it is mild. If any one of them is moderate to severe, that's what we classify, simplified way. Then after this allergic rhinitis, why we delaying a diagnosis, well, let's go into how are they connected to the asthma. Based on 4 prominent features. One is epidemiological data, pathophysiological mechanism, symptoms correlation with allergic response, effective treatment of the united airway disease. Let's look into the epidemiological. 78% of asthma, allergic rhinosinusitis. 38% allergic rhinosinusitis has asthma. The references will be given in the bottom. Patients with allergic rhinosinusitis have 4-fold increase in the development of asthma in the Finnish study for 15 years. And allergic rhinosinusitis patients have 3-fold increase in the development of asthma, the Tucson study over 20 years. Allergic rhinitis have a reactive airway disease decrease, forced expiratory flow 25. Mid-airway obstruction is the small airway, the silent zone, we have to look for it. Nasal allergy challenge shows a cause of reactive airway disease at 30 minutes and persists up to 24 hours. Pathological mechanism, nasal breathing has a protective effect. Mouth breathing worsens the bronchospasm. We have data. Pan airways have same pseudo-stratified columnar epithelium. Inflammatory response is common in diverse diseases like allergic rhinosinusitis and asthma. Inflammatory mediators are identical throughout the respiratory tract and involve T cells and various cytokines. And our symptom correlate with early and late phase response in allergic rhinitis. If they expose to the anyone's allergen, the symptoms of nasal thing start within no time. And after half an hour, it will come down. Again, late phase phenomenon comes up 3-4 hours. Same way, lung functions also decrease, and it come back, and after 3 hours, late phase phenomenon will be coming there. We have data. Effect of treatment. Treatment of allergic rhinosinusitis with the nasal steroid improve with asthma symptoms and also with improvement of the pulmonary function testing. Effective treatment of chronic sinusitis improved asthma, the markers of inflammation. The allergic skin test result have been done in these children. 75% of the house dust mite predominantly. Pollen is 47%, mold 17%, animal dandruff 18.1%. The current treatment, social determinant dictates the terms. Many people want only antihistaminic. 90% want oral medication. They don't want any injection, spray and all this thing. Intranasal steroid been recommended 64%, and oral intranasal decongestant 53%. Only 3% need immunotherapy. Only 3% need immunotherapy. And take-home message, upper airway disease are gaining more prominence. Allergic rhinitis is the most common non-communicable disease. Sneezing is the hallmark symptom of allergic rhinitis, causing significant psychosocial-economic burden. Sneeze is not so uncommon. Various other conditions contribute for the sneezing. Second-generation antihistaminics are the drugs for the runners or seizures. Social determinant dictate terms for oral treatment. Immunotherapy downregulates the inflammation throughout the respiratory tract. Our aim should be to prevent and control the disease and provide quality of life. I like to show one thing. I think Arif is here. Yes, Arif. He's a dear friend of mine, allergist from Hyderabad. And he had one patient. During COVID period of time, always used to come sneezing. Environmental control, you name the medication, everything is Parmish. I don't know what to do with this one. What can I do? Please send the video to me. And usually for 2 hours he used to sneeze in the evening time, like. That's what he said. What is it then? What have you observed me? What I'm doing? Yes, you cannot sneeze without closing the eyes. This boy always kept the eyes open. So that is the clinical clue. I said there might be some family dispute. Find out. We found out finally family dispute with father and mother and all those things. It solved the problem. So, sir? Yes, sir, psychogenic. Psychogenic. Ladies and gentlemen, a healthy breath will always bring healthy life. Let each one teach one, plant one tree. Let all animal species live with us. Let's propagate our Vasudhaiva Kutumbakam, one earth, one family, one future. Let's bring out a better breathing for all the future, for all the species living in this world. Thank you very much for your patient hearing. Sure, I'm right on time. I finished right on time.
Thank you, Dr. Parmish, for the beautiful lecture, and thank you also for finishing in time. I have nothing much to add. I just 1 or 2 words to summarize. That we should look for features of allergic rhinitis in all patients of bronchial asthma, pediatric asthma especially those patients who are difficult to treat. And in many cases, commonly the bronchial asthma patient who have AR has comorbidity, they may not be sneezers, they may be blockers. So as the common concept is, if the patient has AR, he or she will go on sneezing constantly, may not be always correct, there may be blockers also. So that is one important thing. And treatment of, core treatment of allergic rhinitis with intranasal steroids definitely give better responses in those patients. And reversely, if you have patients of allergic rhinitis, and if they do not have any overt symptom of bronchial asthma, those patients should also be looked for features of bronchial asthma, maybe by doing PFT in an appropriate age or impulse oscillometry if it is required. So this is the take-home message. Thank you, Dr. Parmish, once again.
Just one question, can I ask?
Sir, excellent presentation. And sir has again emphasized that clinical diagnosis is more important than depending on investigations to come and arrive at a conclusion of allergic rhinitis. Very excellently presented, sir. I just have one query. They say that the best way of managing allergic rhinitis is intranasal steroids compared to antihistamines. Can you just elaborate on it, sir?
Yes. I think any blockage, the controller medication is needed. Sneezing and running, anything like that, antihistaminics helps. And itching, it helps. But blockage, it won't help. So that's why we have to use the steroids and all. Nasal steroid is the best medication. And direction is very important. How you direct them. It has to be V-shaped. This nostril this way, this way, not to the filter.
Yeah. See, once we start intranasal steroids for allergic rhinitis, because that is the best controller, we give it for 2 months, 3 months, but when we stop the treatment, the patient comes again. So this can happen many times, recurrent allergic rhinitis. So how long we can give intranasal steroids?
I think those type of children, probably we should recommend immunotherapy. Oral immunotherapy has come there. That would be the best thing to recommend now.
Okay. Okay, thank you.
One more question.
Sir, between this antihistaminics, say the newly added belastin, levocetirizine, and your Allegra, that is fexofenadine, which one to choose and which one is better?
I think this topic, nothing to do with the management had happened. I just want to say that I don't have, 3 years I've stopped practicing. I do only environmental preventive medicine. This combination I have not used. I don't have much knowledge in that one. I maybe have something, but not authoritatively. I cannot able to speak. Any one of them can speak. Chairman, I'll be happy.
Most of the intranasal steroid is not below 2 years. Not used below 2 years, intranasal steroid. But we do get patients where in 1.5 or 1 year, child is sneezing again and again, or nasal.
Below 2 years, if you are wanting to make an allergic rhinitis diagnosis, first make sure to rule out other conditions, because below 2 years, as sir has said, for the child to develop allergy and present as allergic rhinitis, it might take at least 2 to 3 years. So below 2 years, first think of other conditions like choanal atresia, adenoid hypertrophy, and if you are wanting to use intranasal steroids, as we all know, it should be the second line, because all of them are validated from 2 years onwards, if I am not mistaken, sir.
I mean, answering his question of which antihistaminic, any of the other antihistaminics are all are equal. You can choose any one. There is no one doesn't have a benefit over the other.
Regarding Basudev's question, I do not have much of experience with Bilastin, but cetirizine is a safe option. Time tested, it works. And the dose is a bit stretchable, because for an adult, our concept was 10 milligram OD, but it can be given 10 milligram BD. And proportionately for a 1 year child, you can give up to 5 milligrams safely. And sometimes it may be, the dose may be increased up to 7.5 milligrams. So, Allegra or fexofenadine is slightly sleep inducing, so that may be a problem, but it works. But the overall experience of at least me, or I think people of my age, that the cetirizine is a very good alternative. And though it is said to be non-sedating, but some people face some problem of sedation, but that is not of much concern. Now, I have a question for Dr. Parmish, that if you treat, a lot of things has been said about the side effects of inhalation steroids. And there are some recent data that they may hamper growth for a very short period, by a centimeter or 2. I don't know whether you agree with me, but what's your take on co-treatment with intranasal steroid and inhalation steroid? Are the side effects or the risks are increased if a patient gets both inhalation steroid and nasal steroid?
I think you already answered, sir. Nasal steroid absorption a little higher than the inhaled steroid, corticosteroid. I think when you're using, combination is needed, and also it's short-lived. When you stop, usually if you use it for a long period of time, yes, I think the growth decreases, but it will catch up later. I don't think anything. Most of the parents are considered about these things. And sleep is the most important. And also, my recent work is on light pollution and its effect on the human health. I think light pollution, it has to be talked about. I think last month we published a paper, and it is how it has got disturbs the sleep. Indu was talking about it. 2 hormones will be secreted at night. One is growth hormone, become taller at night time. Another one is the melatonin, is secreted at night time. It starts at 9:30 p.m., 7:30 a.m. it starts. The 2 a.m. is the best sleep. And sleep is the most important. Medium sleep is a human being 8 hours. The children will be more, it varies. And longest sleeping animal is the bat, 19.9 hours. Lowest sleeping animal is a horse, 2.9 hours. Each animal has got a thing. Nearly 950 million birds every single day die because of the light we are putting on all these things, hitting the, because their circadian cycle will be disrupted and navigation disrupted, they hit the windows. Close the windows at night time. And don't turn off the light at night, turn off the light completely at night time. See, I mentioned about blue light. Blue light is the most dangerous. Through the eye it goes.
Just one point to add, sir, for your query. The second generation intranasal steroids, the bioavailability is very low. So they are relatively safer compared to the first generation intranasal steroids.
One question I have, is there any role of Montelukast in Montelukast? Has there any role?
Montelukast is, at least in the US, it's a scheduled H drug. It should not be the first line of usage for allergic rhinitis. For that, as sir has told, intranasal steroids, antihistamines, and Montelukast comes later. It should not be used as a first line agent. Thank you.
One request, please. We are running short of time, so we can have the questions over tea or lunch.
Just one sentence for the question on Montelukast. See, Montelukast Many people are using Montelukast for many things, but for respiratory system, it is best used for exercise-induced asthma. Now, one issue about Montelukast is if you use it for a long time, it can cause some suicidal tendencies. So my take is if you have to use Montelukast, don't use it continuously for more than 3 weeks. Give 1 or 2 weeks gap, and you may start again, but you must be a bit cautious, especially in younger children. Thank you.
Thank you, sir, for a wonderful session.